we see this all the time in the locums world where there's this instinct to treat locums physicians as kind of the sacrificial lamb scapegoat, for any sort of problem and go, there's a problem, let's just fire the locums. And you can only do that because you don't have a relationship with them, and you've never really taken ownership of that physician's performance and responsibility for it. And and to me, a world where, like you're describing, a world where there's a more intimate connection and knowledge of all of the players, and also the problems in the community, and I think more importantly, there's actual skin in the game by all the parties that are involved in making the decisions. That changes the dynamic, I think, tremendously, from one where, like you said, we're looking at spreadsheets, we're looking at profit margins, and we're looking at categories to trim, and not necessarily thinking creatively about your particular situation, your particular staff, and what other levers you might be able to pull, and get creative locally to address the problem.
Ultimately, all medicine is a human business, but particularly emergency medicine. People are in crisis. It's a human related process. The emergency department is the interface between the hospital and the community many times. And the more that administrators understand how the emergency department is interfacing with the community, the better they are. And here's another one of my little things is that it's not about metrics that everybody looks at. Everybody looks at the, satisfaction and throughput metrics and goes, that's a measure of the department's success. Yeah, that is a factor, but it is not. You can't tell the success or failure of a department based on looking at those metrics. There are very complex reasons why those things don't really reflect what's going on. I think in some respects they're measurable, and that's why people get very fixated on them. And so it's easier to address something that's measurable than things that aren't so measurable. But you can have a tail wagging the dog kind of scenario if you're chasing metrics and that's your measurement. And we're going to get a new group in because they promise us that these metrics will be met. I think, and again, I'm a little Pollyanna about this, but I think long-term stability, success for the institution, relationship, strong relationship of the emergency department with the medical staff of the hospital is an important part of that. And so, some of that requires a little bit of time and effort on the part of everybody to sit down and go, are we operating from the same playbook, rather than just saying, all right, well, we're just going to get a bunch of people in here who can, meet these metrics, and then everything will be fine.
What do you think about? I mean, something that Sycamore is to some extent very interested in is a future where more physicians are more autonomous. And by that I don't mean floaters that have no responsibility or connection. I more mean physicians who are not completely 100% beholden to a single employer, and have more personal skin in the game, career-wise, versus an environment where your entire livelihood and your entire existence depends upon you maintaining your political status, your approval within an organization, to a single employer. How do you think? I mean, that's something that I think would be good for medicine, would be good for individual emergency departments, would be good for patients. Do you agree with that? Do you think that that's something that's worth striving for? Or do you think that that's kind of just a pipe dream?
I think we're in we're in uncharted territory a little bit with the changes that have happened because of the COVID situation. But that the COVID thing, to some degree, just sort of opened up the uh, out, you know, the situation that everybody that was inside of it already kind of knew, which was that the contract management group strategy, which was to pitch metrics and go to hospitals that were challenged and say, listen, we can do a better job because we'll meet all these metrics. That was an older strategy and it was very successful. A lot of groups went in that direction, and then there was a lot of fear, that the reimbursement was dropping. And so, the local groups all sold out because they wanted to get out. And so then you had this, growth of contract groups, which in my mind, I'm not sure what their end game was because reimbursement is dropping. At the end of the day, a hospital needs a functional emergency department. It's part of their requirement as a hospital. They got this department. So then you had COVID come along. And what COVID did, in addition to all the other crazy, dramatic things, is it threw out all the metrics. Because all of a sudden, 40% of your volume went away. So that meant that throughput wasn't an issue anymore. You didn't have people waiting in the waiting room. Satisfaction changed because the people that came in, first of all, you're not having any visitors. And a lot of times satisfaction is poor because it's the visitors that are unsatisfied, not the patient. So satisfaction went away. You didn't have any visitors. The patients were sick as hell. So typically, if you're really, really sick, you're pretty satisfied if you survive and you do well. So all of a sudden, the metrics went out the window. So what we saw was emergency medicine to the core of what it's all about immediately, which was we're the safety net for the community. All of a sudden, all these people were getting sick, and I'm in Connecticut. I was right next to New York. I mean, we were getting clobbered by this, and New York, even worse. And so what happened is it just focused attention right away on the fact that emergency medicine is a critical part of the safety net for the community, the hospital, and everybody involved. So you better make sure that you've got a functional emergency department. And it isn't about patient satisfaction and throughput times and all that. It's about who's there to take care of your family when you get COVID or you're in a trauma. We all knew that. We knew that. Nobody else maybe paid attention to it, or they were paying attention to other things on their spreadsheet. So then COVID blows that up. So then the answer is, okay, so is there a better way to do stuff? The answer is there's always a better way. The question is, what is it? How do you get to it? The concept of having physicians be more autonomous, there's some advantage to that, and that is that physicians like to be autonomous. That's one of the things you notice about high quality physicians is that they have spent a lot of years training and sometimes a lot of money, getting trained, and they want to be able to utilize their training in an environment where they will be rewarded for the skills that they have. I will tell you that most high quality emergency physicians don't feel that their skill set involves throughput time and satisfaction. Now, I'm not saying that they don't want to do that, but their job is to take care of the patient. And take care of the patient certainly means doing it in a timely fashion, and doing it in a way in which everybody is satisfied. So I'm not suggesting that most docs don't like the metrics, but they don't like to be driven by the metrics. So if the department can't meet metrics because of built-in infrastructure, and you put the doctor in that environment and they don't have good metrics, they get very frustrated because it's not because they can't do their job. It's the environment prevents them from having the metrics, that everybody wants them to have. I'll steal something from another friend of mine named Jim Augustine, who's very well known in emergency medicine at the Benchmarking Alliance. he taught me something. It's called good, fast, nice. He said, best ER docs are good, fast, and nice. Really easy to be two out of the three. Very difficult to be all three. So you can be good and fast, maybe not so nice. You can be good and nice, maybe not so fast. So you know, everybody should strive to be all three. There's no doubt that most ER physicians want to get to patients quickly, make them feel satisfied that they, you know, had a good interaction, and they certainly want to do a good job. But what ends up happening in the world of the contracts, particularly, you know, when there's challenges at the facility, is that the docs many times feel like, wow, you know, I'm just being pushed to see people really quickly so that the metrics look good. And it pushes me beyond what I'm necessarily comfortable. So I'm getting pushed to be good and fast, or sorry, be fast and nice. I can't be good. And you want people to be good, and you want them to do you know, what they think is a decent job. Now, you know, having said that, there's a bell curve. There are some people, here's an example. I know myself. I can be fast, and I'm not so nice, and maybe I'm not so good. Uh, and so if there's a challenge to push me to be faster, like if you drop me in an institution that has really bad wait times, the waiting room's always full of patients, and they say, you know, your job's just to crank through this, you know, backlog of patients as quick as possible. I can do that. It's not very rewarding for me, but I can do that. But I can tell you that I'm not going to be as nice, and I'm not going to be as good.